Morning, everybody. I've been given the impossible task of following my friend Kath. So I'm going to do my best, but wow, it's a tough challenge. So I worked with MSF, as you've heard, until 2009, and then with some other colleagues from MSF, founded Alima. And you're going to hear about projects from both of those experiences. The more astute amongst you will notice that the photos tend to be quite old, and that's because as the time's gone by, I've got more and more uncomfortable about photographing what I'm witnessing. But I think I've got enough to illustrate the points I want to talk to you about. This comes from the MSF Nobel Peace Prize acceptance speech. I believe this passionately, so I'm declaring that. And the political failure can be local, all the way up to global bodies, such as we saw recently in the Ebola crisis. I shudder when I think of the naive 20-year-old I was when I saw Michael Burke's documentary on the Ethiopian famine in my third year at medical school, second year at medical school. And there I was at Wembley with everybody else, singing "We Can Feed the World." Well, I now know that there's a really dark underbelly to aid, and that you have to be very, very careful that your project doesn't actually undermine what's already happening in that country. It's far, far better to work with the Ministry of Health in their own hospitals than to parachute in a project. I've been very fortunate to have some really good advice in my career. This is crucial, not just in a resource-rich context, but specifically in difficult contexts. I also got some very good advice from a friend who'd worked with MSF for 10 years when I was first starting out. And he said, "Nikki, it's all about the context. You have to understand the context as best you can. Medically, socially, politically, culturally. It'll all be very similar, but there'll be individual themes that make that context particular. Unfortunately, there's almost always extreme poverty and/or growth disadvantage." So Paul Farmer says that you have to be very careful not to let a health crisis turn into a human rights crisis. And that's kind of what I'm getting at a bit with the underbelly of aid. It really needs to be professionalized. You need 4 S's, this is Paul Farmer too: staff, stuff, space, systems. And as a doctor working in these kind of contexts, you're going to be involved in all of those things. If you think about the humanitarian emergencies, there's not really that many, are there? You know, you're going to have conflict, natural catastrophes, epidemics, the hunger emergencies, which I'm specifically not calling famine, because unlike Ethiopia, when there really was no food in the country, one of the absolutely shameful facts about the hunger emergencies is that there's usually plenty of food in the country. And then the last one is refugees and internally displaced people who actually need primary care more than they need critical care until one of the other catastrophes befalls them, and that's unfortunately often the case. This is where I work in Brisbane. All those the machines that go ping and beep beep. I don't have any of those apart from the pulse oximeter where I work. But it's actually an incredibly refreshing experience to be down here on the law of the diminishing returns curve. Small things make an enormous difference. When I'm in Brisbane, I kind of work up here most of the time. The other thing that's surprising and very informative is that when you can't commit much iatrogenesis, you actually see some really surprising recoveries and need to reflect on how much harm we actually do with our current practices. So these are some common themes which I end up doing wherever I am. Hospital hygiene, spaces between the beds, trying to reduce nosocomial infection. Almost always at the start of the project, that involves actually working with the cleaners. They've never had enough money for the cleaning products or enough cleaners. Encouraging people to throw things away because they're not dirty or it's just that they're thrifty. And if you don't have enough, it's really hard to throw things out. And that would include half-used drug ampules, which get kept for days and days and days. If you think hand hygiene's hard in your ICU, well, try doing it when there's no running water. One of the things that I'm really, really happy to have done with Alima is that we now use the WHO formula, and we make our own hand gel, and there's loads of advantages about that. One is it's cheap, 2 is you can have it everywhere, but 3 is that it's owned by the project. When people are making it themselves, they kind of get excited about using it. And you can use that almost everywhere. It's no good in cholera emergencies. You're inevitably going to be involved in some of these things, and I think Kath's going to talk about blood later. Blood's a very precious resource, and it's a dangerous resource in Africa too. You're going to be involved, there's never enough of it. You're going to be involved in making sure that your quality control's all right, the rapid tests are done okay. You're going to have to decide what you're going to do with the donors who are positive for HIV or Hep B, and now Hep C. We've got a treatment for that now. What are we going to do about that? And you're going to have to worry about the cold chain. And if you've got frequent electric disruptions that Kath was talking about, well, then maybe you need a gas fridge. Oh, the oxygen, the oxygen, the oxygen. Well, you know, this is my 350-bed paediatric hospital in the middle of the malaria season. We do have oximeters. Even with all the resources that we have, it's a Ministry of Health hospital. We don't have enough oxygen for kids with SATs kind of above 84, 85. But there are some common themes. There's always at least 2 of them that are broken. I never go anywhere without my Swiss Army knife and my screwdriver, and I'm pretty good at fixing these now. And unfortunately, at the beginning of the emergency, there's usually one that's still in the packaging, and that's because it got sent, the logistician unpacked it 2 days ago, but he's already left, and nobody knows it's in the store, so I end up having a look around the store pretty early on when I arrive. And then finally, food and nutrition. And I've now got a kind of 1-week meal plan in most countries that I've worked in, because it's amazing what a difference nutrition makes. We ran a project in Iraq for the civilian war wounded, and many of them had multi-drug resistant infections. Fortunately, we hadn't given them to them, they came with them. We'd done the bone biopsies. We knew what the organisms were, the surgery was good. The antibiotics were right, and they weren't getting better. And then we looked at what they were eating and changed that, and it was just like magic. Within 2 weeks, everything changed, and the wounds started to heal. Wherever you are, there's going to be something that's unpleasant about it. It'll be too hot, too cold, too dusty. This was too cold, and there were aftershocks. The other thing is, I like my colleagues in Brisbane, but I sure as hell wouldn't want to live with them. And you're going to be living with them 24 hours a day, and because it's a security context, almost always, you can't go anywhere to get away from them. So you leave for work in the car, you work together all day, often quite late, then you come home. And you start to feel sometimes, unless you find out a way of dealing with it, pretty pissed off with the surgeon who's just used all the hot water. Again, if you're lucky enough to have hot water in the shower in the morning. And he's used the last of your special shampoo that you bought to stop your hair getting frizzy. So that's annoying. You have to work out how to deal with that. This was, again, Pakistan. Natural catastrophe is a little bit different because often all of the infrastructure's gone, and you have to take everything with you. So this is a modular field hospital, so 9 modules that you can clip together, and that's got 2 operating theatres in it. You take all of your sterilisation gear, your operating sets with you. There's a lot of similarities between catastrophes and conflict, because when you're dealing with civilians, I know the military are great at this now, but when you're dealing with civilians in conflict, the patients who get head trauma or chest trauma usually die before they can get to care. And it's the same in most of the natural catastrophes. So what you end up dealing with is patients with horrible long bone trauma, multiple open fractures and huge soft tissue deficits, and that was pretty much what we were doing here. Where you have critical care skills, unfortunately, is almost always going to be in a dangerous setting, and as we know, it's just getting worse and worse with the Americans bombing the hospital in Kunduz in Afghanistan last year, and the Saudis bombing 5 MSF hospitals in Yemen last year. I mean, these are contraventions of the Geneva convention. I won't, I'll get too angry if I carry on. This project was unusual because it was in Haiti long before the earthquake, and there's a huge slum, 1.5 million people, called Cité du Soleil, that lives in Port-au-Prince, and this project was just literally on the border of it. So these incredibly brave guys, some of the bravest people I've ever met, would go in, literally scoop and run the patients. By necessity, it was low-volume resuscitation because that was all they could do. And we would have the patients with us, and if necessary, in theatre within 20 minutes. So here we were dealing with multiple gunshot wounds, chest, abdomen, head wounds. And there I learned how amazingly well I'd been trained, because do you know what? You can do thoracotomies without a bronchoscopy and a double lumen tube. You can do one lung ventilation like that. Ketamine is always your friend. And even though these airways are challenging with this horrible facial and head trauma, actually they're not impossible. You can manage them if you've been well trained. What about the post-op analgesia for patients with thoracotomies? We all know how important it is that they breathe and cough and move. Can't do epidurals, way too dangerous in this kind of setting. But what I used to do was walk around with a trolley in the morning, some sterile gloves, lots of dilute Marcaine, put it down the chest tubes, wriggle the patients about, and kick them out of bed the first day and make them move. So it's amazing what you can do if you've been well trained. I've put this here because there's almost always a ventilator that someone donated stuck in a cupboard somewhere. It's never been serviced, no one knows how to use it, but with your Swiss Army knife and your screwdriver, you can get it working if you really want to. The problem is, if you choose to ventilate this patient, and I did choose to ventilate this patient because he'd aspirated loads of blood and stuff when he'd been shot in the face. And I thought if I had a short period of time to do some pulmonary toilet and stabilise his gas exchange, he would actually survive and do well. And I only had to ventilate him for 3 hours. But during that time, I couldn't take anyone else to theatre. And I had a ward of 50 post-op acute trauma patients that I couldn't look after either. It's a very big decision to ventilate somebody if you are lucky enough to have a ventilator. I've had about 3 terrible days over the years. This was one of them. We'd been dealing with gunshot wounds all day, been operating all day. I thought it was finally time to go home. And on the tuk-tuk came 2 little girls. This one that you see here, and another one who was about 15 kilos, and they both had gunshot wounds to the head. They both needed to go to theatre. I wasn't at all confident that even if I'd had the resources, in terms of human resources, to ventilate them, that ventilator was going to be safe for kids. I knew it would be all right for a while on that big bloke, but I wasn't at all confident with that ventilator. So I took the first one to theatre, recovered her, extubated her, and then got on with the 15-kilo child. And obviously I was there all night, but they both made an astonishing recovery. And again, I gave thanks to the extraordinary way that intensivists are trained in Australia. People are a bit surprised to find out that wherever you are, whether it's a catastrophe or a conflict, between 40 to 80% of your work's actually going to be obstetrics. It's going to be fulminant eclampsia or awful, awful situations where women with obstructed labour have walked miles and miles and miles with a macerated fetus and have sepsis. Or it's going to be somebody who's had untreated PID and has a ruptured ectopic. And even if you're an adult intensivist, you're going to get pretty good at neonatal resuscitation pretty quickly. This was actually so rewarding. So this is Pakistan. It's the earth will quake. It's freezing, freezing cold. And these little ones got born on the mountainside, and people were living in tents, and some of the aid that was sent was just ridiculous. So people sent thousands of tents, but they weren't winterized tents. They were kind of tents for Africa. And so these little ones would come in, and they were hypoglycemic and hypothermic and septic. And it was amazing. If you didn't do anything stupid and you just did the simple things, they got better really quickly. This is the malaria season in Ivory Coast, and I'm sure Kat's very familiar with this. So these little ones, they've all got hemoglobins. This particular group of about 2, they've got severe malaria, they've got high output cardiac failure, and they've often got some sort of sepsis on top of that too. Again, if you don't do anything stupid, and you have some simple resources, it's amazing how well these kids do. This is one of my favorite things. This is a Nellcore oximeter used extensively by MSF and Alama, and the reason I like it is that it's pretty forgiving. You can kind of bounce it anywhere and fill it full of dust and water, and it just keeps on working. Epidemics. The basics of epidemic care are really straightforward, aren't they? It's case management, which is where we would be involved, maybe. Contact tracing and surveillance, and if you're lucky, some laboratory function. But what about if your your surveillance tells you that your cholera epidemics just flared up here in the mountains and there's nothing there? This is us putting together a 200-bed cholera hospital, which we managed to do in 24 hours. So I did knock a few tent pegs in till the logs told me I was crap, and it would be much better if I went and got on with doing something that I was good at. So that's a cholera bed for those who've never seen it. Very, very practical. Put the patient there, and all the rice water stool can just drip through. You don't have to change the patients all the time. What you see here is the squeezing through of fluid, life-saving. But what about if you've got 200 patients and they all need 6 to 10 litres of fluid a day, but how the hell are you going to keep track of it? Because you're certainly not going to be filling in fluid charts. Texter, just write the number on the bag. Keep writing the number on the bag. There's this constant tension between quantity and quality. Now, if you arrive breathing at a cholera treatment centre, you really shouldn't die. It's a bit more complicated if you're pregnant, but you really shouldn't die. And especially if you've got easy IO there too, which is probably one of the most useful things that you can kind of add. But I look at this and I'm just horrified by the lack of kind of dignity and respect and privacy here. And we grappled with this after the epidemic in Haiti. And I think we've cracked it now. For those who were at the Ebola talk yesterday, you see we had screens between each of the beds using what my French friends call plastic shitting. We have plastic shitting, Nikki. And I think that's what we'll do next time. So I'm going to finish up by talking about malnutrition. Since the invention of plumpy nut, which is the stuff that you see in this sachet here, it's just really peanut butter with milk powder and multivitamins and trace elements, invented by a friend of mine, André Briand. Most malnutrition emergencies can actually be treated in the community, and it's been revolutionary. So for MSF during the famine in Angola, they opened their biggest ever therapeutic feeding centre, and even with all of their resources, they could only treat 800 patients because you needed to use therapeutic milks 8 times a day. And since we've had the ready-to-use therapeutic feedstuffs, you can go into a hunger emergency and treat 60,000 kids as an outpatient. It's revolutionised the treatment. This little child's having an appetite test, which sadly he failed, and he needed to be admitted to hospital, about which we'll talk next. That's his grandmother. His mother died of AIDS, and unfortunately, he has HIV too, we subsequently discovered. I would never take a photo like this, and I was quite horrified that one of my colleagues had taken it. The only reason that I've kept it is that this is Ibrahim a week later. So these are the children that I help to look after. Most of the work's done by my African colleagues, and I must emphasize that. It's a great shame that you can't see the bottle of alcoholic hand gel at the end of the bed, but I guarantee you it's there. So he comes into hospital, we reintroduce feeding, we treat his malaria, as is common with these really sick kids. They have an enteropathy, partly associated with their severe malnutrition, partly with their malaria, with gut translocation. And he had a gram-negative sepsis, but we treated him also for the gram-positive sepsis that they often get with the skin lesions that go with kwashiorkor. So I'd like to finish on a positive note. And this is a piece of work that I'm just so delighted to have been part of. We use, and you may not all be aware of this, but a simple bracelet that costs 8 cents to screen children for malnutrition. And you put it around their upper arm, and if it's green, they're okay. If it's yellow, they've got moderate malnutrition. If it's red, they've got severe malnutrition. And this has been kind of secret medical business done by community health workers who have to walk to all of the villages that they screen, and they usually only get to them once a month. And André Briand, myself, and Thierry, another colleague, had lunch together in 2009 when we were founding Alima, and just went, well, why the hell aren't we teaching the mums to do this? And of course, the people who are invested in the current kind of arrangement would say, well, it's because, you know, they're still children themselves virtually, they're illiterate, they're innumerate. Well, we did a pilot, we proved that it was possible with some very, very basic training. And then we went on, this has just been accepted for publication, we went on to do a pragmatic non-inferiority trial, so a health district, 100,000 people, usual treatment, and another one with all the demographics and incidence of malnutrition as similar as we could get them. And we trained 13,000 mums. And it was cheaper, not surprisingly, you didn't need to pay them anything. But of course, the thing is you could get them to screen their kids every week on market day or whenever they were worried. And what we've shown is that it's not just not inferior, it's better. The mums present with their kids earlier, less of them need to go to hospital. And even more exciting, when you go back a year later, 98% of them have still got this precious little thing that costs 8 cents. So I hope this is the future. We're going to empower the mums and help them to participate in their childcare and start looking at what we can do to change this situation in Niger. So, well, not just in Niger, around the world. Thank you very much for your time.
Thank you, Nikki, for such an amazing talk, and congratulations for this lifetime work. Sarah?
So many comments are coming through, people just feeling inspired and humbled by the work you're doing, feeling that we probably don't have any room for complaining about our normal bad days. If somebody wanted to follow in your footsteps, would you have advice for them or strategies for how to best help?
Sure. Well, the first thing I would say is that I'm actually usually inspired and humbled by the people that I work with. I do very little compared to what they do. They live there. It's their life. I go in and I come away again. It's a hard life. So if somebody's thinking about doing it, it's a hard life. I don't think you can really do it and have kids because it's dangerous. You can't take your kids with you, and if you want to be with them, then that's difficult. I also think one of the most useful things you can do in the world is actually probably give the world healthy, well-adjusted people who care about justice and social equity, so that's another thing you can do. But if you do want to... For a number of reasons, I don't have children, so this is what I did instead. You have to have a job with some really understanding colleagues in the resource-rich world because you're not going to be there all the time and you might leave at short notice. It's probably a really good idea to do the Diploma of Hygiene and Tropical Medicine early. I did it after I'd been in Mount Isa doing Indigenous health in Australia for 10 years, and I wish I'd done it at the beginning and not the end. The course that Mike Dobson runs on anaesthesia in in underdeveloped countries is excellent, and it's only 3 or 4, I can't remember, it's 3 or 5 days, so I do that too. And then there's no question that MSF is the kind of university where we've all trained, and where if you're going to acquire skills which might be useful later in a setting like Alama, that's by far the best place to acquire them, outside something very surprising like the earthquake in Haiti, where we were able to take kind of first mission people and we just needed everybody quickly. And if that happens, you'll be getting an email from me, all of you, if I can persuade SMACC to send them to me. So, yeah, that's it probably. I'm a good psychiatrist.